Thank you so much, Kylie. It's an absolute pleasure. And I'd like to thank Central and Eastern Sydney for asking me to speak tonight on a topic that's close to my heart, and that's menopause. So let's hope the technology works. I'll just try and share screen and all that. I love it when it comes together. This is good. Can I just check with my friends out there that that's visible?
Yes, thank you.
Lovely. Okay. Well, we're going to talk very practical things about menopause management tonight. So I hope that's what people want to hear, because it's certainly where I think most of us have the most questions. So first of all, the declaration of interest. Basically, I have worked for various pharma companies who make various kinds of menopause hormone therapy, and I've in the past, although not for some years now, as I'm sure you'll all agree, received support for conference attendance. I've also been doing some work as a researcher at the Royal Hospital for Women in trials that are sometimes looking at menopausal hormone therapy products. My contact details are down there. I'm very happy to receive emails from anyone at any time. But the most important line of this is that I really want to acknowledge the contribution of a number of my really, really good friends, Rod Baber, Professor Bronwyn Stuckey, and Jenny Ning, who helped with the authorship of some of these case studies. So I really do appreciate it. So let's start by going right back to the very beginning. And one of the things I was asked to talk about was the sort of way a menopause consultation might go. And I think obviously every woman is going to be different and every need is going to be different, but this is like a suggested framework. And I think the most important thing is to establish the nature and the timing of the symptoms that are most troublesome. Often menopause is a very complex situation, and knowing which symptoms are bothering that woman most, I think, is the logical place to start. I also think because menopause is a normal time of life and not a disease, it's important to ask what the patient herself wants from therapy. That gives you an idea of her own personal philosophy, what she wants to do, what she's tried before. And then I think obviously provide the information. So we're going to be talking about menopausal symptoms, lifestyle modification, and of course we're going to be talking about the various kinds of treatments we can discuss with that woman. So if we're talking about troublesome vasomotor symptoms, then I think we have some choices. Many of our patients have already tried some of the non-pharmacological treatments. There are a number that are evidence-based that do work, and that's things like purpose-designed cognitive behavioural therapy, weight loss and lifestyle modification. So that's things like losing weight if somebody's overweight, because we know that increases the number of hot flushes, stopping smoking, because again, we know that increases the number of hot flushes, dressing carefully in layers so that you can peel off as you don't need it anymore. And I've got at the bottom there a big question mark around herbals, because I think we all use them and certainly our patients do. But there's not a huge amount of evidence to show that they're all really that effective. So a big question mark around them. I think the important thing here is do no harm. And the one that probably has the most evidence behind it is remifemin, which at least has gone through some, albeit fairly small and limited clinical trials in Germany where it was actually first marketed. We then, of course, can talk about hormone therapy, and it does remain the gold standard. And obviously, most of my presentation is going to be on that tonight, so we'll just park that to one side. And then, of course, there's the non-hormonal pharmacological treatments. And we tend to use these when somebody can't or doesn't wish to use menopausal hormone therapy. I'm going to talk a little tiny bit about them, just in one or two slides. But of course, we can use things like escitalopram or citalopram. Venlafaxine is probably the most commonly used. Paroxetine, it's just one important thing to remember there is that you're not supposed to use it in somebody who's actually on tamoxifen. Gabapentin can be used, clonidine, and the new kid on the block is oxybutynin, which we're starting to investigate a little bit more at the moment. Whatever you do pharmacologically, it's important to review the efficacy after about 1 or 2 months. We do have some women, though, who just have vaginal symptoms, in which case we don't need to use systemic treatments at all. I think the important thing here is perhaps not to buy the symptoms straight off. So we need to examine that woman to exclude things like bacterial vaginosis or other vulval disorders like lichen sclerosus or just dermatitis. We need to make sure that there's no history of breast cancer, or we're not supposed to use the topical vaginal estrogens. I might challenge that a little bit as we speak, but certainly that's the current thought. If we do have somebody who has a breast cancer history, then the usual things that are offered first are things like vaginal moisturizers, or you can, as I said, discuss the possibility of using vaginal estrogen with the patient and their treating oncologist. Certainly the College of O&G in their present guidance is much more accommodating of the idea of using vaginal estrogen in a breast cancer survivor who's tried some of the other things and it hasn't found them effective. We can also get down and practical here. For discomfort that only occurs during sexual activity, advising patients around the use of lubricants, particularly things like silicone-based lubes. The thing about water-based lube, which I guess we're all a little bit more aware of, is that it does tend to be absorbed into the skin fairly quickly. And that means it loses its slipperiness, where silicone doesn't. So advising people to just, go out there and shop for a silicone-based lube can make all the difference. And of course, if the woman's complaining of just external dryness, a bit dry when I'm walking around, then a bland emollient is probably the way to go there. And of course, all these things can be used together. So let's talk about menopausal hormone therapy in more difficult circumstances. And I guess what I'm talking about here is that the prescription that you give to that patient needs to be tailored, taking into account the patient's own preferences, their comorbidities, potential side effects, and very importantly, the phase of menopause that they're actually at. So pros and cons, a nice little, cogent list here. So we look at the pros. You get relief of vasomotor and of course other symptoms of menopause as well, although that's less well evidenced. Relief of vaginal symptoms, you get slowing of the bone loss that can lead to hip and spinal fractures. And we all know that the time that we lose most bone is in that 3 to 5 years after menopause. Some studies suggest that it might really, reduce the risk of colon cancer. And also we do believe now that it may be cardioprotective if we start it early enough, not late, but if we start it within that first 10 years after menopause, there may be some protection, which goes against what they found in the WHI study way back. The cons though, we still believe there's a small but increased risk of breast cancer over time, that there's an increased risk of venous thromboembolism, and that's from the time we initiate therapy, but that risk increases with age, simply because the background risk increases with age. We do believe there's an increased risk of cardiovascular disease and stroke if we initiate this therapy later. And there is an increased risk of endometrial hyperplasia if we don't use adequate amounts of progesterone to protect the endometrium. And again, that's something I'll talk about a little bit later. It's important to get the mix right. These graphs tables are actually from the Australasian Menopause Society website. And those of you who haven't gone there already, can I commend it? It's amazing. Really great information for both you and for your patients. But you'll also find these little tables here, which give you an idea of the products available in Australia and whether they're low, medium or high dose. And they're absolutely invaluable. Now, this one's just for estrogen, but we'll talk in a minute about the fact there's also some for progestogens and some for combination therapy. But estrogen alone menopausal hormone therapy, of course, is daily estrogen with no breaks. We can only use this in somebody that's had a hysterectomy. And for that reason, we don't need to use a progestogen because, of course, there's no endometrium to be protected. They come as tablets, patches, gels. All this is partially patient preference, but we do believe these days that transdermal delivery is safer, particularly if you've got risk factors for venous thromboembolism, or you might have somebody who's not absorbing particularly well through their gut. The recommendation is to start at low or moderate doses. And as I said, have a look at these AMS sheets if you're wondering about where the particular preparation you're considering fits into that schema. You do need to add a progestogen in a woman who's got a uterus. So the progestogen, and that's either a synthetic progestin, okay, or a progesterone. Okay, progesterone is the natural hormone that's made in the latter part of a normal reproductive cycle. So we can use a synthetic or a body-identical kind of progestogen. It's essential to protect against endometrial hyperplasia and in the long term to protect that woman against uterine cancer. We use cyclical progestogen if the woman is less than 12 months from the time of her last menstrual period. One of the nice things about menopause, of course, is that your periods stop. And unfortunately, that's not the case if you start someone on cyclical therapy. We need to warn the woman that there will be regular monthly withdrawal bleeds on this form of cyclical menopausal hormone therapy. And that's designed into the preparation to allow that somewhat thickened endometrium to bleed over several months and get thinner and thinner and thinner with time, till eventually we hope it stops doing that and doesn't require that bleed to stop irregular bleeding occurring. We can, of course, use the combined oral contraceptive pill or the ring if the woman is under the age of 50 and there are no obvious contraindications to its use. And I mean, obviously, this also provides contraception, which can be an issue for the woman at this time of her life. This is probably at age 50, not the time that she's thinking about achieving a pregnancy. And we can also use these in an extended fashion, so skipping the placebo pills or the ring-free break to avoid regular bleeding. I tend to use estradiol pills quite a lot in this older age group, partly because there is some evidence that they're better than synthetic estrogens for bone maintenance. But a low-dose pill or a ring is a perfectly acceptable option, as I said, provided that woman doesn't have contraindications. You can start a continuous progestogen menopausal hormone therapy if it's more than 12 months since the last menstrual period. Now, if you do that, that should produce amenorrhea with no regular bleeding, but we will accept a little bit of irregular spotting for the first 3 or 4 months that she's using it. After that, any irregular bleeding on hormone therapy really does need investigation. You can also use a Mirena IUD as the progestogen part of menopausal hormone therapy in a woman of any age. Just a little caution there, the new Kylena, the smaller levonorgestrel IUD that's hit the market in the last 12 months or so, is not licensed to be used as the progestogen part of menopausal hormone therapy. So if you do have somebody who comes to menopause with Kylena, you just can't start estrogen as you can with Mirena. Here are those other tables I told you about. So estrogens you've already seen, progestogens are over there on the other side of the slide, and down the bottom, there are a number of preparations where the manufacturers have put it all together for us in one combination therapy, and they're both pills and patches. I think it's a good idea to change from cyclical or sequential menopausal hormone therapy at 12 months to a continuous preparation rather than just leaving somebody on that cyclical HRT. The reason for that is that some women will stop bleeding. As they go down through their cyclical therapy, they will stop bleeding, and then of course you can trial a continuous preparation then. But some women will continue to get a regular bleed if you leave them on the cyclical therapy, and that's not a necessary thing to do. What happens if you start the continuous therapy and she experiences breakthrough bleeding? Then the recommendation is to go back to cyclical therapy for another year and try again later. So what's new on the block? Well, the newer preparations that we've been seeing in the last couple of years are mainly centred on reducing the potential risks or side effects. So we're seeing more use of micronized progesterone, and it's not new. Dydrogesterone has been around for a while, but we're starting to use it a little bit more because some studies indicate that both of these have a lower risk of venous thromboembolism than the older synthetic progestogens we've used conventionally up till now. Micronized progesterone also may, and I've got a big bold on that, it is a may, it's not been proven, but it may have lower breast cancer risk than synthetic progestogens. The other new kid on the block is conjugated estrogen and bazodoxifene, which is a SERM. This is called a tissue selective estrogen complex, and it has no progestogen in it, which has obvious advantages for those women perhaps who have side effects from a progestogen they've used in the past. Let's have a look at micronized progesterone a little bit more closely. It's a body-identical progesterone derived from Mexican yam. Now, I'm not saying this thing is natural. I hate that word because it's made in a factory, but it's chemically identical to the progesterone that's produced late in the cycle in a luteal phase. It binds only to progesterone receptors. Synthetic progestogens tend to bind to androgen receptors. They'll sometimes bind to other receptors and sort of that can cause, I guess, side effects that you perhaps don't want. So they tend to produce fewer adverse effects than synthetic progestogens do. The progesterone particles are reduced in size from 92 to 6 micrometers. That's the whole micronized thing, and it just means it's better absorbed through the gut and through the skin. You get maximal serum concentrations 3 hours after you administer it orally. A couple of practical things: oral absorption is 4 times higher when it's taken with food than when it's taken if you're fasting. It has a very short half-life, so adherence is important. If people take micronized progesterone erratically, they'll tend to get a bit more bleeding than they would on a synthetic progestogen. The other interesting thing is that progesterone can have a mild sedative effect. So the recommendation is that it's best taken at night. Now, that can be an advantage if you take it at night. Many menopausal women have trouble sleeping, and this can be an advantage. But if you don't like it, then vaginal administration can be considered, because it produces a more stable serum level and you don't get that sedative effect. It is completely off license. It's used this way in many other parts of the world, and it's used in IVF in Australia, but it's not licensed for use in menopausal hormone therapy. If you decide to do it, then you don't need as many tablets. You can actually administer the micronized progesterone vaginally every second day, rather than taking it every single day orally. Every second day is tricky though with a 7-day week. So what many of us are doing who use this is to get the woman to take it on Mondays, Wednesdays and Fridays or something like that. How safe is it? Well, randomized control data 2-3 years, a long time ago now, 1996, found that endometrial hyperplasia rates were equal to placebo at low to medium estrogen levels. We don't know how it's protective at high levels. That study's not being done. And we also know from a big French study, a cohort study, these micronized progesterones have been used for a very long time in France as their preferred progestogen. We do know from the studies done there that there was a possible higher rate of endometrial hyperplasia in users with long-term use. Now, whether that's because people were using it with higher levels of estrogen, we don't know, but it is a bit of a cautionary tale. Now, what is it? It's suspended in oil with a soft gelatin capsule, and that's why you can use it vaginally, because if you put it in the vagina, it dissolves and the oil is then distributed in the vaginal skin. They come as 100 milligram capsules on private prescription. You get 30. Cyclically, the idea is that you use 200 milligrams. So that's 200 milligram caps from day 1 to 12 of the month. If you're using it continuously, then it's simpler. It's just 100 milligrams a day. And as I said to you before, it may be safer to use the breast cancer risk. And this is this big study I talked about before, the E3N cohort study in Europe in 2008. And they found that up to 5 years of use, there was no increased risk of breast cancer. So if you have a look at the chart over on the left there, you'll see that estrogens in terms of breast cancer risk to this 5-year mark, okay, cross that line in the middle, and that means that there's no significant increased risk. Estrogens, progestogens, oral progestogens sit over to the right of that line, and that makes them a slightly increased risk. If we go down to the bottom, this is estrogen and synthetic progestogens that have been used transdermally or as a estradiol pellet. Sorry, or as a transdermal or a pellet. And again, you've got an increased risk with that particular use. But again, if you have a look at what I've circled there, which is the transdermal estradiol plus micronized progesterone, it offers no greater risk than estrogens alone. The other thing about micronized progesterone is that when you pair it with an estrogen, it does seem safer regarding VTE risk as well. So there's a couple of potential positives there at least. So who would be the sort of people you might consider micronized progesterone in? Well, it may have some safety advantages, as I said, over some of the other menopausal hormone therapy regimens you might consider. And for that reason, you might make it your preferred regimen for most women. It's also quite useful, I think, if somebody wants to continue menopausal hormone therapy after the usual 4 to 5 years of use of a synthetic progesterone, say something like combined patches or Mirena plus a patch. you certainly could consider using micronized progesterone plus estradiol. But do I have any great long-term safety data to say it's better long-term, no problems? The answer to that, of course, is no. As I said, the other thing is that the micronized progesterone binds only to progesterone receptors. So you do tend to get fewer progestogenic side effects than you get with synthetic progestogens. So this is one to consider if somebody comes along on another preparation complaining of things like moodiness or irritability. The drawbacks for its use are that it's not PBS listed, so it's costly. There's a degree of lack of convenience because you're taking two things rather than a single patch, for example, and that there's insufficient data for safe continuous dose to cover higher dose estrogen and long-term risks of endometrial hyperplasia. So those studies are continuing, but we may not have the answers for some time yet. I wanted to talk about these TSECs, these tissue selective estrogen complexes. And as I said, they can replace the progestogen in combined hormone therapy as long as they suppress the endometrium. So they've chosen in bazodoxepine one that does that beautifully. And they've combined it with conjugated equine estrogens, and I've given you the dosages there. And there's no doubt that it improves hot flushes, it improves vaginal atrophy, it improves bone mineral density. It gives no increase in breast density, but the breast cancer risk of these preparations is simply unknown. They haven't been around long enough. They do avoid progestogenic side effects. You tend to get a better bleeding profile than you get with conjugated equine estrogens and medroxyprogesterone acetate. So they're an alternative to estrogen and progestogen menopausal hormone therapy for postmenopausal women with an intact uterus who can take an oral estrogen. Of course, all of you out there prescribing at the moment will know that these things are incredibly difficult to get at the moment, along with other hormone therapy preparations, both for contraception and for menopausal hormone therapy. This is the transdermal estradiol gel. It's delivered in a pump pack as a daily dose gel. Each metered dose delivers 0.75 milligrams of estradiol. The usual starting dose is 2 pumps, which gives you 1.5. 2 pumps is equivalent to about a 50 milligram patch. Now, it must be combined with progestogen in women with a uterus, but they do make it now with a companion micronized progesterone in the same packet. And that makes it a little bit more convenient and a little bit cheaper than buying the two separately. You need to apply the gel to as large an area as possible. It's an alcohol-based gel, a bit like hand sanitizer, and you put it from the shoulder to the wrist with each pump dispensed. So you put one pump on one arm and the other pump on the other arm. And for those women who need higher dosages, then you can use the inner thighs to apply it as well. It has pretty much the same benefits as other transdermal patches and gels. It does go into the skin a bit more readily than the Sandrina, which we've been using for many years. I was asked to talk about tibolone. I think it's an important thing to remember as being there. It's a synthetic oral steroid. And what happens is when you take it, it's metabolized into the liver, into a component that looks like an estrogen, one that looks like a progestogen, and one that looks like an androgen, all in the one tablet. It is on private script, but it's not a particularly expensive drug to buy. It's a very old drug and really quite comparable to the PBS in price, but perhaps not for our patients on healthcare cards. It's a continuous preparation of 2.5 milligrams. Because it's continuous, users must be more than 12 months post-menopause. It's comparable in symptom control to low or medium conventional estrogen, progestogen, menopausal hormone therapy. The bone effects are comparable to menopausal hormone therapy. You do get less mastalgia and you don't get any change in mammographic density. And that can be quite useful because it means that if you do have a small breast cancer, it's probably going to be easier to see. The risks, well, the absolute risk increase in strokes is 2.3 strokes per 1,000 women treated per year. Breast cancer survivors, it was hoped that it might be an option for breast cancer survivors, but in fact that trial was ceased early because although they didn't get any local recurrences, or not many, they did find more distal metastasis in tibolone users. So the bottom line is it's got pretty much the same contraindications and risks as conventional menopausal hormone therapy. But I do think it's useful in women who have side effects on other things you've tried, and it is the only androgen licensed for use in Australia. So certainly consider tibolone in a woman who's complaining of things like decreased libido or decreased energy levels. Okay, case 1, chaos theory, I've called it. This is Lisa. She's age 47. She's got 12 months of irregular periods, varying in amount. She's previously had a pretty regular cycle. She's also had alternating hot flushes and nostalgia for the last 6 months. Until 6 months ago, she was using fertility awareness for contraception, but that's getting much trickier now. The GP suggested that she might like to try a low-dose 20 microgram estradiol pill, along with levonorgestrel 100 micrograms. Now she's getting hot flushes in the placebo week. She's otherwise really well. She's a non-smoker. Her BMI is 25. We know that she's perimenopausal. We don't need any tests to work that out. You can do that straight from the history. So I think what Lisa needs are control of her cycle, management of her menopausal symptoms, and contraception. This is some work done by Georgina Hale at Sydney University. And what she did was get a whole bunch of menopausal women and drew blood from them at various times in the cycle to chart what their hormones are doing. And this just illustrates what we all know about perimenopause. It depends when you take the blood as to what sort of levels you'll get. So this is looking at estradiol, progesterone, LH and FSH in the lower part of it. And I think what's most striking is if you have a look at something like A here, the shaded section is actually menses, okay? And what's happening is you can see you get these huge amounts of estradiol in some women just at or just before menses. And this explains why some of these women can get quite significant nostalgia. And it also explains another thing, which I'll go on to talk about in a minute. But I guess the bottom line is in the individual woman, levels of hormones at perimenopause are absolutely chaotic and pretty much unpredictable. And it's very hard to get any, reliable hormone test to tell you exactly where things are at any particular time. These are more of Georgina's figures, okay? And she observed these 29 women through their transition phase cycles, and 37% of them experienced this estradiol rise that started soon after the luteal phase, which she called a luteal out of phase event. Now, it does lead to high estrogen levels, and these women will complain about things like nostalgia and bloating and increased headaches. And you can even see quite high levels of FSH if we go down the bottom there. And that, at the end of the cycle, leads to early follicle recruitment and maybe multiple follicle recruitment. And that's a pretty dicey situation if that woman's looking not to fall pregnant. And it's sobering, I think, to realise that the highest rate of unplanned pregnancy in Australia is in teenagers, but the second highest is in the over 40s. And that's, I think, because many of these women think they're too old to get pregnant. So contraception is advised for 1 year if menopause occurs after the age of 50 from the last period, and 2 years if she's under 50. Now, if we were to start someone like Lisa on hormone therapy, that's going to control her vasomotor symptoms quite well, but it won't give her any cycle control. And this is this whole thing about trying to time cyclical hormone therapy for someone who's still got endogenous cycling of their own. It also doesn't have any contraceptive effect. And the really tragic thing is that if she's in one of those cycles where she's making heaps of estrogen, and then we've given her a hormone therapy on top of that, that will in fact make her estrogenic symptoms worse, not better. We could start someone like Lisa on the contraceptive pill or the ring, which is what her doctor has done. That overrides the natural cycle and provides contraception and symptom control, so tick in quite a few boxes. But of course, it can only be used in those with no risk factors. The other thing about the pill is, of course, unlike hormone therapy, it has a whole week or perhaps less of placebo pills. And during those pills, many women will find that they get breakthrough of their menopausal symptoms. We could use a progesterone-only pill or an implant or an IUD. Now, these all provide contraception, but no control of menopausal symptoms. No estrogen, obviously. So we're going to require add back estrogen in some way, shape or form. We can use estrogen alone with the Mirena hormonal IUD, but we also need to note that the Mirena IUD does not suppress the cycle. So just like the pill, you may get some months where she's got high levels of estrogen and things like, nausea and breast tenderness, and other months where that doesn't occur. That's something, I guess, to think about when you've got somebody on Mirena plus estrogen patch or gel. However, what we can do is we can combine menopausal hormone therapy with the others as well. So if she's on a progestogen-only pill or she's on an implant, we can't just add back the estrogen. That's against the rules. There's no safety data on that. But we can have her on the mini pill and use combined menopausal hormone therapy as well, or we can have her on an implant and use combined therapy. It's off license, but it's certainly very often done. The other nice thing these days is we've just had access to a new progestogen-only pill which completely suppresses ovulation. So that I think is going to be very useful as an option in these older women as well. And if she's got symptoms, then we can add back a low dose of menopausal hormone therapy as well. We could, of course, use a copper IUD. They're safe because they've got no hormones in them. Unfortunately, they do have this tendency to make bleeding heavier, and this is often one of the problems that women have going into menopause anyway. So probably fairly low on our list of choices unless she has a really light, painless bleeds. We could also recommend barrier contraception, but of course barriers are going to be less effective for contraception generally, and some women will make that choice. She certainly, as she gets older, is less likely to fall pregnant, but often the effects of pregnancy, if she does, are a little bit more earth-shattering. So personally, as I said, I use a lot of estradiol pills around perimenopause, provided, of course, she's got no contraindications to pill use as, in general. They do have exactly the same contraindications that the combined pill has generally, so we can't use them in someone where you wouldn't use a pill in. I think it's useful for symptom control. People tend to do better in terms of hot flushes with estradiol rather than ethinyl estradiol. And as I said, there is some work that shows that it does control bone, or it tends to preserve bone density a little bit more effectively. Now, both the brands that are available in Australia contain a similar estradiol dose to conventional menopausal hormone therapy. They provide symptom relief, they provide cycle control, they provide contraception, and both the preparations that are available in Australia have quite short unmedicated phase. So 2 or 4 pills, which often is enough not to get breakthrough flushes. Or of course you can use back-to-back. Zoli is a little easier to do that with than is Clara. Clara is very hard to get at the moment too, just let's pretend it was here. The other thing you can do is you can actually use an estrogen patch during that pill-free week if you wish. This is case number 2, and it's titled Blood is Thicker Than Water. So here's Amy, she's 50. She's an admin assistant. She's married with 3 kids. She's really fit. She's a non-smoker. She hardly drinks at all. She's blood pressure's, something to be proud of. She had a venous thromboembolism following an anterior cruciate repair after a skiing injury at age 40. There's absolutely no other relevant history. She has no family history of VTE, and the thrombophilia screen that was done at the time of her clot was negative. She's had significant vasomotor symptoms for 12 months, and they haven't responded to the herbal and complementary therapies that she's been exploring so far. So the big question here is, can Amy use menopausal hormone therapy with her history of VTE? Now, the thrombotic risk associated with menopausal hormone therapy depends on the route of estrogen delivery, the type and the dose of estrogen, and the progestogen that it's paired with in women with a uterus. Now, oral but not transdermal estrogen increases the prothrombotic factors through hepatic first pass effect. So you get activated protein C resistance. The use of oral menopausal hormone therapy doubles that woman's baseline risk of VTE. So if you're 50, it goes from 1 in 1,000 to 2 to 3 in 1,000. Okay, still not a huge risk, but a risk, and one that needs to be discussed. How do we know all this? Well, the best study is still the old WHI. So if we looked at placebo and used that as a risk of 1 as our reference, if you're using estrogen alone, that risk goes up to 1.32. If you're using estrogen plus medroxyprogesterone acetate, that went up to 2, or just over 2. And if you happen to be using that and you were unlucky enough to have factor V Leiden, it went up quite substantially to 6.7. So at least equine estrogens plus MPA increase the VTE risk in that particular study, and we've extended that to a caution beyond that particular study, but we know that there's also other things associated with VTE risk. So as we get older, our risk gets higher. If we're overweight or obese, the risk gets higher. So there are other things we need to take into account when giving women advice over VTE. We do know that the highest risk is in the first year of use, but that persisted for 5 years of follow-up. So it's not something that's just associated with that very first time that you try it. So we need to individualize those thromboembolic risks to assess all the women that we see who ask us about menopausal hormone therapy for the risk factors that might predispose them to the development of VTE before they commence it. So we're talking here about smokers, obesity, family history, and a first-degree relative. All those things will increase the risk. If there are risk factors, you can use menopausal hormone therapy, but there are factors I think that you need to consider. First of all, I would use a transdermal estrogen. That shouldn't increase her VTE risk up to at least a 50 microgram patch. That's where the studies stop. We can use lower dose of estrogen if her symptoms are controlled. We can use different progestogens. We believe there's less risk. In fact, it's demonstrated there's less risk with micronized progesterone or dydrogesterone. We haven't got head-to-head studies between oral and transdermal estrogen, but we do have quite a few epidemiological studies, and they've not found any risk. This is from a trial, a review by Ravinsky, and you can see it's a meta-analysis of 22 studies, postmenopausal women, no prior VTE, and the VTE risk was not increased in users of transdermal menopausal hormone therapy. But if you have a look at the figures below, you'll see that they were on the oral therapy, much to the same level as we saw in the WHI just talked about. So bottom line is that Amy could consider using menopausal hormone therapy according to the US Endocrine Society statement of 2015. And they say that VTE due to past immobility, surgery, or bone fracture is not necessarily a contraindication to transdermal therapy. So what do we use? This is a study done by Canonico, and it's just, I guess, illustrates what I've been saying. This is where it comes from. As VTE risk is not increased with transdermal estrogen, plus or minus micronized progesterone, if she's got a uterus, that would be the preferred choice for Amy. So key messages here, I guess. VTE risk depends on the type and the duration of the progestin you use. Transdermal estrogen plus most synthetic progestogens increased the VTE risk. Transdermal estrogen plus body identical progesterone, that risk was not increased. So that would be our first choice. Similarly, micronized progesterone and dydrogesterone do not appear to affect coagulation parameters, but we can't get dydrogesterone on its own in Australia. Oral E2 is associated with, is contraindicated in women who've had a previous VTE or thrombophilia. So we wouldn't use oral therapy in Amy. Observational studies and meta-analyses support the use of transdermal E2 in those with higher risks, with the risks we talked about. And the use of, but bottom line again, the use of all menopausal hormone therapy is still contraindicated for women with a past VTE that's secondary to the pill or previous menopausal hormone therapy use, or for those women who've got a known thrombophilia. The other thing, of course, is Amy could consider those alternatives we talked about in our first couple of slides. So venlafaxine and paroxetine in low doses can reduce the incidence and severity of hot flushes by up to 60–70%. But I should just say as a proviso that all the trials that were done on this were relatively short, about 3–4 months max. Fluoxetine and sertraline work, but they're slightly less effective. They're not for everyone. 16% of women in the trials who were pretty motivated withdrew due to side effects, things like breast symptoms and sexual dysfunction. Clonidine, old-fashioned antihypertensive at 25 milligrams BD, there's evidence of a 40% reduction in hot flushes. Gabapentin and pregabalin are also useful, but they are expensive and they do have side effects, particularly sleepiness. So we tend to reserve them for sort of last choice rather than first. And as I mentioned at the beginning, there's a lot of interest at the moment in oxybutynin, which of course is used for incontinence. And 2.5 to 5 milligrams BD has been shown to reduce the severity and incidence of hot flushes by something equivalent to your SSRIs, SNRIs, by about 70 to 80%. So if a woman can tolerate the atropine-like symptoms, things like dry mouth, then it may be an option for her. Okay, our third case. My head is exploding. Here's Sally. She's age 48. She's got 2 adult children from a previous marriage. She's now in a same-sex relationship, so contraception is not an issue. Her blood pressure is great, 126/80. She's a little bit overweight. Her BMI is 28, but she's otherwise very healthy. She takes no regular medication. She's a non-smoker and a social drinker. She describes menstrual irregularity for the past 3 years, and most recently 3 months of amenorrhea until she got a bleed about a week ago. She also describes hot flushes, night sweats, and severe intermittent breast tenderness. However, Sally has a history of migraine with aura since her teens, which has been more frequent over the last 12 months. A little brief word on migraines, and I'm sure you all know much more about them than I do, but migraines are more common in women than men. The prevalence of migraine peaks at 30% when women are in their 40s. Migraineurs intrinsically have a higher background risk of CVA. 25% of migraineurs experience an aura. And interestingly enough, migraines without aura are the ones that are more likely to be associated with hormonal fluctuations than migraines with aura. So many of these women that you see with migraine increasing in severity and frequency around menopause are actually going to be those without aura. The oral contraceptive pill, as everybody here knows, I'm sure, is contraindicated in women with focal migraines, migraines with aura, since it's believed to increase the risk of CVA. However, menopausal hormone therapy is not contraindicated in menopausal women with migraine with aura. However, it's not the panacea. It may improve it, but sometimes it might make no difference at all, and sometimes can make the migraines worse in some women. And of course, at any age, it's important that we optimise otherwise her migraine therapy. Now, why does this happen? Well, falling estrogen levels seem to be able to trigger hormonally sensitive migraines. This is why they occur in the pill-free week on the pill. Now, we said at the very beginning that widely fluctuating hormone levels are really common during perimenopause, and that's probably why many women find that migraines increase in frequently in severity at this time. Let's put some figures around it. Studies suggest that up to two-thirds of women with migraine did report improvement after menopause when these hormone levels settle down. However, 35% reported no change, and some women described an increase in severity and frequency, as I said before. And the problem is that both these studies that I've quoted didn't make a real distinction between migraine with aura and migraine without. So I think that needs to be teased out a little bit more. But we do know that the type of migraine does tend to be important, with the frequency of migraine with aura less likely to settle down with menopause. So how do we manage it? Let's look right at the beginning, early perimenopause. At that time, the menstrual cycles are still pretty regular and the cycles are mainly ovulatory. So we can use a little bit of mini prophylaxis for those women who get those menstrually related migraines. So they can use a transdermal estradiol gel or patch for 1 to 2 days prior to their menses, and they continue for 5 days to try and prevent that rapid fall in E2 that's going to occur at that time in their cycle. If she has no aura, you can, of course, use an oral contraceptive pill to suppress the physiological cycling and provide her with contraception as well. Back to what I was saying before, I believe that the newer estradiol pills may be a better choice at this time. Consider extending the cycles or using a shorter pill-free interval. So if you're on a conventional pill, you can still say only take 2 to 4 sugar pills and start with your new active pill after that. And as I said before, you can also use a weekly estradiol patch during the placebo break to prevent an estrogen withdrawal trigger. What about late perimenopause? Now, during this time, the periods are going to be more irregular and the cycles are going to be mostly anovulatory. The effect of estrogen withdrawal on migraine severity and frequency tends to be more evident during this particular phase. Again, you can use a pill if she doesn't have an aura or doesn't have any other contraindications, but you can only use it to age 50. It's age limited. You could consider transdermal menopausal hormone therapy to even out those hormonal fluctuations, but there's a couple of things here you need to be thinking about. Transdermal estradiol with Mirena IUD is an option if she's sensitive to progesterone. Transdermal estradiol with cyclical micronized progesterone can be considered, but irregular bleeding is more of a problem. Now, after menopause is established, as I said before, you might find that migraines simply improve with those stable, low estradiol levels. If she requires treatment, the transdermal route provides a much more stable estrogen delivery system, and oral therapy, unfortunately, might worsen symptoms in some of those patients with migraine with aura. The other thing to remember is that a higher estrogen threshold might exist for migraine prevention. So these are women that you might consider a higher estrogen patch, 100 micrograms rather than a 50 microgram patch. Continuous progestogens may be better tolerated than cyclical, but if you use them very early on, you may find that you're going to get more of that breakthrough bleeding. So it's a bit of a juggle. Case 3 is the curse. Here's Priya. She's aged 40 and she's had severe dysmenorrhea from her early teens. She had endometriosis diagnosed when she was having treatment for infertility. She's had 2 kids through assisted conception procedures. She had a laparoscopic hysterectomy and bilateral salpingo oophorectomy about 2 months ago. At that procedure, extensive endometriosis was noted with numerous bowel adhesions to the posterior uterine wall, which required division, and they also saw an endometrioma on the left ovary. She's now presenting with severe hot flushes, insomnia, extreme tiredness, and arthralgia. So she's menopausal. Endometriosis is the presence of ectopic endometrial tissue, obviously. And we know that estrogen is a very potent stimulus to endometriosis growth. The cessation of ovulation that occurs at menopause or at oophorectomy or medically, as we do with oral contraceptive pill use, often settles down endometriotic symptoms, but not always, because of course there is that inflammation that's present, and of course there's also central sensitization to be taken into account. Why do we want to stop ovulation? Well, follicular fluid at ovulation has something like 4,000 to 5,000 times the level of estradiol than you see in the blood. So I guess this raises 2 questions. Is it safe to give menopausal hormone therapy post-menopause to someone who's had endometriosis? And the questions here are, is it going to cause a recurrence or could it contribute to malignant transformation? Let's have a look at the evidence, and unfortunately there's not much of it. There's one small retrospective observational study, only 123 women, mean duration 42 months of estrogen versus estrogen and progestogen after surgery. Now they saw 3 cases of recurrence and 3 cases of recurrent symptoms, so pain, that sort of thing, and 1 case of recurrent endometriosis in the estrogen alone group. Hardly something to shout from the rooftops. It's a small study. There's also a systematic review of 17 case reports of recurrence on menopausal hormone therapy. 12 patients had estrogen alone. 4 patients were on cyclical estradiol and progestogen. 1 patient had an unspecified regimen. The majority had quite extensive endometriotic disease previously, and most of them were on high-dose therapy. What about malignant transformation? Well, here we've got a case control study, again, only 31 cases versus 62 controls. They found a non-significant increased risk of postmenopausal malignant transformation of endometriomas, particularly in patients on unopposed estrogen. The odds ratio were even higher if that patient was obese and on unopposed estrogen. There's a systematic review of case reports of malignant transformation of endometriotic foci with menopausal hormone therapy. 24 of them were on unopposed estrogen, 4 had testosterone as well. 1 patient was on a cyclical progestogen regimen, and endometrioid adenocarcinoma was the most common pathology that was seen. So where does all this lead us? Well, just to the fact that evidence remains sparse. So we've got these case reports of recurrence, but there's not very many of them. However, the current recommendations suggest that we continue to use combined estrogen progestogen preparations instead of unopposed estrogen for women with a history of endometriosis, even after hysterectomy, particularly if there's been extensive disease. But I guess the bottom line here is that we really need further studies to more accurately assess the safety of MHT and the optimal regimen we should use in these women. Case 4, the enemy within. Here's Angelina. She's 39. She's an actor and activist. She's got 6 children. She has a BRCA1 mutation, and that was identified after her mother was diagnosed with breast and ovarian cancer, and her maternal aunt diagnosed with breast cancer. Angelina had bilateral mastectomy and reconstruction 2 years ago. She's thinking about a risk reduction bilateral salpingo oophorectomy. She's seeking some advice about the safety of menopausal hormone therapy and whether to undergo hysterectomy. So obviously, in someone with potential for breast cancer, the decision to use menopausal hormone therapy is a shared decision based on her medical history, symptoms, quality of life, family history, and her own personal philosophy. The lifetime risk of breast cancer is around 1 in 8 for Australian women. Estrogen alone menopausal hormone therapy, we believe that there's no increased risk until at least 7 years of use, and that's from the WHI data. With combined menopausal hormone therapy, we see a small increased risk after somewhere between 4 to 5 years of use. That attributable risk is small. It's less than 0.1 per 1,000 women per year of menopausal hormone therapy use. And that risk is similar to being obese or having more than 2 alcoholic drinks a day. The increased risk of breast cancer associated with, did I put that twice? With MHT is estimated less than 0.1% per annum, or as I said, less than 1 per 1,000 women per year of use. In the WHI study, 7.1 years of treatment with unopposed conjugated equine estrogen actually decreased the risk of breast cancer diagnosis and mortality in hysterectomized women. The risk of breast cancer with MHT is primarily associated with the addition of progestogens. And observational cohort and case control studies, which I'll go to in a minute, do suggest there may be differences in breast cancer risk, depending on the progestogen in the preparation. So this is the E3N study. It's a French study. It's a cohort study looking at large numbers of French women and what they've been using. The mean duration of treatment of these women was 5.8 years on hormone therapy. So you can see again that the estrogen alone crosses that relative risk line of 1. So that's considered not significant. So too does the transdermal estradiol and micronized progesterone. It also crosses that line, so it's not supposed to have a significant risk. But if we look at oral progestogens plus estrogen, synthetic progestogens plus estrogen, then we are looking at an increased risk of breast cancer. This is another study, the Cecile study, again, a French study, and it looked at breast cancer among current users of menopausal hormone therapy with treatment. It actually divided them into less than 4 years and 4 years, but the mean duration of treatment was around that 4-year mark. Estrogen alone crosses the line, not significant. Estrogens plus micronized progesterone, again, cross the line. Estrogens plus synthetic progestogens do seem to indicate an increased risk of breast cancer. Back to the BRCA mutations, 1 in 400 women carry a BRCA mutation. Carriers do have a higher risk of breast and ovarian cancer. If you've got BRCA1 by age 80, your breast cancer risk is 72%, ovarian cancer 44%. If you have BRCA2 by age 80, the breast cancer risk is 69%, ovarian cancer risk 17%. If you have a risk reduction bilateral salpingo oophorectomy, that reduces the risk of ovarian cancer by 80 to 96%. It also reduces your breast cancer risk by 50%, and obviously then your subsequent mortality. The recommended age is 35 to 40 years for those with a BRCA1, or 40 to 45 years if you have a BRCA2. But when you do this, of course, you get acute onset in relatively young women of severe menopausal symptoms. You chance reduced bone density over time and compromised cardiovascular health. Bilateral mastectomy reduces your future risk of breast cancer by 90%. And there are certainly some women who would choose active surveillance breasts or chemo prevention with something like tamoxifen or aromatase inhibitors. Hysterectomy is not of proven benefit for cancer prevention, but may have other benefits in terms of hormone therapy. Sorry. So let's have a look at a few scenarios. If we're looking at BRCA carriers, we might have someone with intact breasts and ovaries. We might have had someone who's had a risk reduction, bilateral salpingo-oophorectomy and still has intact breasts. You might have someone who's had a risk reduction and mastectomy, or you could have a risk reduction, mastectomy and hysterectomy. So let's look at somebody who carries a BRCA gene, and we're talking about increasing, we're talking about whether or not we can use menopausal hormone therapy after risk reduction surgery. And there's a whole bunch of studies I've given you here. I won't label them, but you can see with every single one of them, there's no evidence of increased risk of breast cancer after a risk reduction surgery. So certainly if in fact you have someone who's made that decision, have had their ovaries removed because of BRCA1, you can be very reassuring about the risks of them using hormone therapy. So menopausal hormone therapy is not contraindicated. Sorry, you can use it in somebody that's had who has a known BRCA mutation. You cannot use menopausal hormone therapy in breast cancer survivors. We don't have any randomized controlled trials on safety otherwise in BRCA carriers. We have limited data from observational studies suggesting that breast cancer risk is not increased with short-term menopausal hormone use in women without a personal history of breast cancer. And most international and Australian guidelines support the use of menopausal hormone therapy in these women until the average age of menopause. So increased breast cancer risk in BRCA1 carriers is not associated with MHT or duration of use, and MHT following risk reduction of oophorectomy in BRCA carriers does not increase the risk. And there's a few references there at the bottom to support that data. So let's just put it in sort of flowchart form. We have someone who has a BRCA mutation 1 or 2. They've made a decision to have risk reduction oophorectomy plus mastectomy. So then the question is, do we remove the uterus as well as the ovaries? And the thing about hysterectomy is it increases the operation complexity, so that's a definite con, but you then only have to use estrogen alone therapy, and that seems to be safer for many women. It's certainly more convenient. And of course, if you remove the uterus, you don't have to worry about endometrial cancer. If she decides not to have hysterectomy, then she's still committed to use estrogen plus progesterone, MHT, and having a uterus still there means that she is still at endometrial cancer risk. If she has the oophorectomy and no mastectomy, but has a hysterectomy, again, we have the operation complexity, we have estrogen alone MHT, and we don't have the risk of endometrial cancer. So pros and cons there. If she has no hysterectomy, then there's quite a few cons. We do need to use estrogen, progesterone, menopausal hormone therapy. We increase the breast cancer risk if we, if we use a combination therapy over estrogen alone, and there is the potential for endometrial cancer in women that we treat with tamoxifen. So it is a discussion that women need to have in terms of planning their risks generally. In the WHI study, breast cancer risk was primarily associated with the addition of the progesterone. There was a small increased risk of breast cancer in the combined therapy. With estrogen alone, there was a reduced risk of breast cancer. And as I said before, there's evidence that estrogen alone does seem to be safer than combined therapy. In a prospective cohort study of 871 BRCA carriers after oophorectomy surgery, overall, there was no increased risk of breast cancer with any menopausal hormone therapy at a follow-up of 7.6 years. And after 10 years of follow-up, the cumulative incidence of breast cancer was 22% for estrogen and progesterone versus 12% for estrogen alone. So it is a much bigger procedure to contemplate, but there is certainly some advantages in considering hysterectomy at the same time as the oophorectomy. The International Menopause Society recommends that if you do have a uterus still, that micronized progesterone is the preparation of choice. And that's because 3 observational studies have demonstrated this lower breast cancer risk with micronized progesterone or dydrogesterone compared with those synthetic progestogens. And I've shown you some of those studies already. So, key messages, I guess, here. Short-term use of menopausal hormone therapy does not appear to increase breast cancer risk among BRCA carriers without a personal history of breast cancer. The benefits of hysterectomy should be balanced against the increased surgical morbidity. If the uterus is intact, micronized progesterone is probably preferable to a synthetic progestogen. And most guidelines recommend limiting menopausal hormone therapy in these women until age 51, which is the natural age of menopause. And of course, non-hormonal options should be offered, but they're usually not as effective, especially in young women with surgical menopause. The next big question, I guess, is how long can you safely use menopausal hormone therapy? And I think we've gone from the sort of set, 5 years and, everything stops after that, to the realization that there is no set minimum or maximum duration. We should be using the dose that controls the symptoms for as long as we need to use it. But we do need to be building in regular reviews. So at least yearly review and a major review at that 4 to 5 years of use. I think it's worthwhile considering every few years trying a lower dose or to talk about perhaps weaning off and stopping. If the symptoms return, then of course we can rediscuss those risks and benefits, taking into account the woman's updated personal and family history. The one group that really should stay on menopausal hormone therapy are those with premature ovarian insufficiency. So those who come to menopause before the age of 40 or right on 40. And even those with early menopause, say those who come to menopause at 41, 42, 43. These women really should continue to use menopausal hormone therapy at least till age 51, both for their symptoms and for the prevention of chronic disease. We know that if these women aren't on some form of hormone therapy, they're at an increased risk of heart disease, osteoporosis, and dementia. So the final take-home messages. Estrogen-containing menopausal hormone therapy is the most effective method of treating menopausal symptoms. It is the gold standard. But the problem is that no one formulation suits everyone, and we now know there are differences in safety between the options we can choose. Modification of the menopausal hormone therapy regimen may be required by modifying the dose, the delivery system, or the time that we use it. And of course, we have to take into account coexisting medical conditions such as thrombophilias, migraines, perimenopause, endometriosis, and BRCA mutations, as we've discussed this evening. And of course, there is a place for non-hormonal options when hormones are contraindicated in the woman before us or declined because they're against her own personal philosophy. And that's the end of my presentation, so I'll ask if there's any questions. I'll stop sharing.
Thanks, Terri. That was fantastic. I think the perfect amount and type of information for GPs. There's certainly a few questions, so I might. So is micronized progesterone available in pharmacies under what trade names is it available in Australia?
Oh, sorry, it's called Prometrium.
Okay.
Prometrium. Yeah. And if the Pro Pack, the pack that comes together, excuse me, you can get a packet that contains both a month's supply of the gel and a month's supply of oral Prometrium. And that's called Estrogel Pro. And I think the two of them, if you buy them separately, cost around about $60. If you buy them in the one pack, they cost about $50.
Okay. What would you recommend for loss of sex drive with menopause, particularly if the patient has had breast cancer?
Oh, so tricky. The problem there is that we don't have any really good data except for testosterone. Excuse me. So there is some good evidence, and if anybody wants a really good overview around testosterone, libido, and its place, there's a great webinar on the Australasian Menopause Society website, which I can commend. It's really fabulous. and it obviously stars the guru of testosterone in Australia, who's Sue Davis. But after breast cancer, you really can't use any hormones. I mean, that's unfortunately the reality. These days, I think we're starting to feel more comfortable about using particularly Ovestin cream for women who have menopausal symptoms genitally, okay? So very thin vagina, which might cause them a great deal of discomfort during intercourse. And that's really common in women who've been treated for cancer, breast cancer, and are using the aromatase inhibitors particularly, or tamoxifen. And it used to be a really big no-no that you could not use vaginal estrogen in these women. These days, I think most people believe that at least Ovestin is very unlikely to get to the sort of levels that are going to cause any problems. So I've been having a bit of success in the women that I see with that particular issue. If it's mainly pain that's causing the trouble, going through things like making sure that the vagina is there's an emollient to keep the vagina skin as healthy as we can, making sure that the woman is using a silicone lube during intercourse, that sex is gentle, okay, and that there's plenty of arousal and lubrication before penetrative sex is even attempted. But at the end of that, if that's not working, then negotiating with the patient's oncologist or breast surgeon and saying, you know, can we use a little bit of vaginal estrogen is often a worthwhile thing to do. In the big scheme of things, it's unlikely to make any difference to recurrence, and it may make sex a lot more comfortable. Overseas, they have a local testosterone cream that you put on the vagina. Still not supposed to be used in breast cancer survivors because some of it is aromatase to estrogen, but it has the advantage of having an effect on the muscles as well. Unfortunately, we don't have it here. You're not supposed to use tibolone in breast cancer survivors, but I guess that would probably be my first port of call in somebody that didn't have breast cancer and was complaining about lack of libido. But, excuse me, just have a glass of water. The other thing that I think really deserves attention is that libido in women is a very complex animal and often not hormonally based. So I think you also have to look at the woman's social situation. You know, if she's holding down a job, you know, the adult kids just won't leave home. Her husband might be sick, her parents might be sick. She's probably juggling 5 or 6 things altogether. And then at the end of the day, often the last thing she's, you know, wanting to think about is sexual intimacy. So sometimes I think you also have to look at the lifestyle and be realistic, you know, about the conditions that make for good sex and trying to optimize those. Looking at the relationship, I mean, there's study after study after study that shows the quality of the sex is pretty much dependent on the quality of the relationship. And I do think people do tend to get a bit lazy as they get older sexually. So, you know, go through the same patterns, do the same things. So looking at that as a way of perhaps, you know, reigniting that pilot light is worthwhile. I said testosterone cream is used, but not in breast cancer survivors generally. But it is something that some people use in an effort to increase libido and energy. It works, in my estimate, about 50% of the time if you get to the right dosage. There's no long-term safety data, so you've got to be very careful to, you know, get informed consent from anybody thinking about using it in. If I use it, I usually bring over the product from Western Australia because it's a high-quality product. It's actually in MIMS. It's called Androphene, and I think you can get it from pharmacies across the country now, just recently. But if I'm going to use it, I only use it in women that have got a testosterone level in the lower third of normal female. I use it for 2 or 3 weeks and draw some more blood from the other arm that she's not putting it on. Otherwise, you get elevated levels. And I'm going to try and keep her within that sort of higher but normal female range. You can continue to get improvements for up to about 2 months. And if it's not making much difference at that stage, I don't think there's any point in continuing it and, you know, taking whatever risks you can. But there are some women it does make a difference in which case, you know, it's done with informed consent. And some women do find that it makes a huge difference for them. The only other thing I would say is we were talking about the social situation, and I use a bibliotherapy a little bit. There's a wonderful book by Rosie King called Where Did My Libido Go? And it's got this woman searching under the bed frantically to try and work out where it's gone. But it's got some really great tips and some really great conversation starters with your partner that can actually make sex better for a couple that have been together for a very long time. And, you know, I often find women will come back to me and say, you know, it has made a difference. Just thinking about it and changing the conditions around sex has actually, you know, made things different for us as a couple. So it's hard. It's what everybody wants to know. And I think it's biologically, it's not surprising that libido goes down as we get older, because at 40, we've only got half the levels of testosterone we had when we were 20. And, you know, as we get into our 60s, those levels become really, really reduced. Now, that's not to say you can't have a great sex life. I know many women who do, because, of course, the biggest and most important thing with our sex lives is our brain, not our vagina and not our ovaries. But sometimes that just requires that a bit more effort than it did when you were 20. A bit like, you know, you don't run as fast or jump as high either. So just a bit more effort. I hope that answers the question.
Yeah, that's all very good advice. Yes, no quick fix.
No quick fix on that.
To everyone's disappointment.
No.
Now, another question.
Kylie, can I just say too, there's a whole bunch of stuff that's available at the pharmacy. You know, Maca and Wild Women and all sorts of weird and wonderful things. I don't recommend them. There's absolutely no evidence they make any difference. They're relatively expensive. There's even a preparation with a bit of menthol you're supposed to rub on your clitoris to make you tingle, and that's just cruel. So, no.
Okay, this question here is, if a woman has been placed on the combined oral contraceptive pill for menopausal symptoms under the age of 50, what do you do when she turns 50? How do you know if she still requires contraception? You
don't. That's the easy answer. The hard part's what you do from there. You need to stop it and see what happens. Now, I have some women at that stage who are very happy to take their chances with regards to pregnancy. Others will say, look, I'm happy to use condoms for 3 months. They've changed the rules a little bit. What you need is an FSH that's above 30, in which case you can then wait 12 months and say that they're probably not going to be needing contraception anymore, but it's only if they're not menstruating. Okay, so if they get another period, the time frame starts again. So you can do that. You can do that if they're on progesterone contraception. So you can still get a reliable FSH if they're using an Implanon or a Mirena. You can't get it on the pill. And you can't even get it if you take it in the pill-free week. So you really need to stop it. Get them to use condoms or, you know, spermicide. There's a blast from the past. Get them to have non-penetrative sex for a couple of months or whatever, and see what happens. And if they start getting hot flushes all over the shop, yes, they're probably menopausal, but you just don't know where they are. And it's going to be quite tricky to work that out. And it's only time and looking at the patterns and looking at the FSH levels that are going to give you that answer.
And just to follow up from that, just confirming that no menopausal hormone treatment provides suitable contraceptive cover.
Only the Mirena. So if you've got somebody who's got a Mirena, you can leave it in for the 5 years that it's supposed to be used and just add back some estrogen, and it provides her with excellent contraception, and of course also provides her with menopausal hormone therapy. But apart from that, no. So you have to use something as well. And that's where I think the new pill, the Slender, is going to be quite useful. So you can use the pill up till menopause. And look, I really wish that somebody would do some safety data on something like Zoli, because, you know, they actually make a menopausal hormone therapy marketed in Europe that's very similar to Zoli. Okay, but the problem is that they haven't done the safety data for the pill we have. So we can't recommend its use after the age of 50, and every international body says the same thing. But I'm really quite excited by Slender, which is the new drospirenone-only mini pill that's just hit the market in the last few months. Last month, only in the last month. It became available, I think, 2nd or 3rd of August. Now, it's drospirenone-only pill, but it has all the advantages of a combined pill. So it completely stops ovulation. So it's as effective as a combined pill. It has a 24-hour window, so that, not like the old mini pills, we had to remember to take them within 3 hours and nobody could. And it also has a 4-day placebo break. The idea being that it will hopefully induce a bleed on a more regular basis. But what they found in the trials is that, a bit like hormone therapy, the longer you used it, the less bleeds you had. So by 12 months, I think only 50% of women were getting a bleed. So with that, you're going to get effective contraception that's safe to use till 55. Okay, and you could add back and just put them on HRT as well. But it has to be combined HRT. You can't just add a patch in and hope it works, because there's no safety for that. You can also do that with Implanon. So if you have an older woman who's using an Implanon and it's within date, then you can add back in some HRT. You could add a patch, a combined patch in, and she will get contraception from the Implanon and relief of her symptoms from the combined patch. There's no reason you can't do that.
And what about the Marina past 5 years in a postmenopausal woman? How long would you consider using it for?
The experts in the UK say that you can use it for at least 7 years if you had it put in after 45, or up to the age of 55, okay? But that's only for contraception. If you're using it for hormone therapy, you can't use it longer than 5 years, okay? Now, again, for me, that makes very little sense. If it's causing enough endometrial suppression to stop you getting pregnant, I would hope it will cause enough to be there for you in your HRT regimen. But that's not what they say. And the reason is that they simply haven't done the long-term data. So, don't have the long-term data. The studies only go out to 5 years for HRT. So we don't know how safe it is.
Okay. Just checking the time. We might have maybe 1 or 2 more questions, because there are a lot here. For women who have mostly non-vasomotor symptoms like joint aches, fatigue, brain fog, is menopause hormone treatment worthwhile?
Yes, it is. It's really interesting. I see quite a lot of women of Asian background in my practice, and they very often have those aches and pains and joint pains and things, in fact, more commonly than they get hot flushes. And they usually do respond to menopausal hormone therapy. It's definitely worth trying. If it doesn't, then you stop it, but definitely worth trying. I'm surprised how often some of those other symptoms settle, even though they're not the classical vasomotor symptoms we all think about.
Okay.
Brain fog. Just a question, little thing on brain fog. Brain fog is most common around perimenopause. One of the nicest things you can say about brain fog is that it usually does get better with menopause. So, that can be at least reassuring, so you don't feel that you'll never be able to find that car in a car park ever again.
Could we get your opinion on what you say to patients requesting Troche hormone replacement therapy, or who are on it?
Look, I basically say that unfortunately there's no long-term safety data for it. That they use pretty much the same hormones that are available in the commercial preparations that they can buy from their pharmacists a lot cheaper than they can buy them from where they're obtaining their Troches. They are exactly the same medications. And at least we've got some safety data on them. So I tried desperately to try and get people to use an estradiol plus micronized progesterone preparation. I can be talked into testosterone. They very often come with testosterone as well, and I can be talked into that, but at least in the sort of dosages that I can keep control of. The real problem with many of these preparations is they use things like salivary levels to keep an eye on what levels we're getting, and they're not reliable. So, many of these women are really using dosages that we're not quite sure what they're getting. And anecdotally, at least, I work with John Eden at the Royal, and he sort of collects endometrial hyperplasias on long-term Troche therapy, just because I don't think the micronized progesterone that they're using is always as good as it could be.
Okay, I might ask one last question, then we might have to hand over.
Okay.
Regarding migraine with aura, neurologists and endocrinologists recommend no menopause hormone treatment. because of increased cardiovascular disease risk?
I'd like them to hit the Menopause Society website, maybe. I think that's old-fashioned advice. I think that if we accept these days that if you start these medications early enough before there's any significant disease, so if we're talking about starting these medications, 51, 52, 53, rather than 61, 62, 63, they should in fact be slightly protective rather than the other way around. That's, I think, what many of the international menopause societies believe. And that's, I think, the thinking behind the whole menopause thing. I would use always a transdermal in the lowest dose I can in that group. So again, perhaps they're thinking a little bit more about estrogen that's oral without some of the advantages that transdermals have. But yeah, I guess I'm going on the evidence that I've seen, and I feel comfortable about using it in women who've got migraines, because often it's miserable for them, as long as it's transdermal and as long as it's lower.
I promise. So just letting you know that Health Pathways, both Southeast Sydney and Sydney, are here for you, supporting care 24/7. Here we go, next slide. So if any of you aren't familiar with Health Pathways, please get in touch with the teams. We'll happily show you how to use them. I've got QR codes there so that you're more than welcome to jump in and use it. We've got our username and passwords. So it's not at all restricted. As long as you're someone working in healthcare, you're able to use it. It won't cost you a thing. It's a collaboration between the PHN and the local health districts, as well as St Vincent's and Sydney Children's. So on the Southeast Sydney page, we have a bit around gynae. These are actually where you can go to refer on to a specialist. There's lots around contraceptive devices and sexual health checks, and we've also got more in development. If you want to see some menopause ones in there, get into the website and provide feedback and let us know that. We definitely listen to what you say. And then the Sydney Health Pathways have been around for a lot longer, so they've got quite a few around menopause there that you can see, and they've got many more as well. So you're welcome to jump into either site. You can use either of the passwords will get you into both sites. We share those to make it easy. And these are the contact details for the team. So please get in touch if you want a hand to navigate around the site. Thank you very much for having me.